Good afternoon, everybody, and welcome to the Gynecologic Pathology Community of Interest. I'm Anna Plotkin. I'm Director of the Continuing Professional Development at the Department of Laboratory Medicine and Pathobiology at the University of Toronto. And today we have a keynote speaker that will be introduced by Dr. Anjelica Hodgson, who is co-moderating the session with me today. Just a couple of housekeeping items. Please fill out evaluations forms that you will see in the beginning and at the end of the session. That's very important for us. We read every single evaluation and we try our best to put your wishes for the next meeting. And then you'll all get CME credits based on your attendance. I would like to ask Anjelica to introduce our keynote speaker.
Thanks, Anna. So it's a pleasure to introduce Dr. Lien Hoang, who is joining us from Vancouver. Dr. Hoang is a gynecologic pathologist at Vancouver General Hospital and a clinical assistant professor with the University of British Columbia. She did her pathology training at the University of British Columbia and fellowship in gynecologic pathology at Memorial Sloan Kettering Cancer Center. She is an author in the new 5th edition WHO classification of female genital tumors Blue Book, and she has published on a number of topical topics, including uterine mesenchymal lesions, glandular lesions of the cervix, and vulvar squamous neoplasia, which is what she is going to discuss with us today. And we are very, very excited to have her. Lynn?
Great, thanks for the introduction. I will just share my screen with you here.
And while Lynn is sharing, please type your questions in the chat box. We'll be monitoring and ask subsequent questions to our speakers and case presenters. And thank you for everybody for sharing their cases.
Great. So for the first part of the talk, so basically, you guys probably already know this, it's a presentation. And what I really wanted to go over was some of the key changes and key highlights in reporting for vulva cancers, and mostly that applies to squamous cell carcinomas. But so we'll go over this first, and then I have some complementary cases that I hope are going to help you in your daily practice. Realistically, I think vulva is something that most people dread, like in gynecologic pathology. Even if you're an expert, it's probably one of the hardest fields or hardest areas in gynecologic pathology. So I hope that you can get, a little bit of your feeding on the ground for these type of lesions. They are exceptionally hard. So, sorry, it's a bit frozen here. Okay, so for this talk, so again, we're just going to go over some of the recent reporting guidelines and the recent changes, the key items, and we'll go over the cases. So in the past couple of years, it's been sort of a frenzy for vulvar cancer. It's actually kind of funny because vulvar cancer hasn't really taken off for so many years. And then all of a sudden, there's been so many changes that have happened in vulvar cancer. It's really, really hard to keep up with. Probably some of the first pivotal changes were published in the WHO 2 years ago in the 5th edition, and we'll go over some of the key changes. The ICCR came out with a new reporting guideline in 2021. FIGO also came out with recommendations in 2021, and then CAP came out with their reporting guidelines in 2022. And actually, ESGO came up with another guideline later in 2022. So, it's been a lot has been going on. So this is a really timely talk to attend. So, these are the key items that you'll see in your pathology report. Most of them are fairly standard. Most of them you will encounter with a variety of other tumors, but I do just want to touch upon some of the sort of key features that have changed in the most recent years. So the first item to talk about is histologic tumor type. So histologic tumor types, so for the ICCR and for the CAP, which are really the major reporting guidelines for cancers of most organs, really. This only applies to epithelial tumors, so we're not talking about melanomas or sarcomas or malignant mesenchymal tumors. And this encompasses all the squamous lesions, adenocarcinomas, and then you have your rare salivary gland tumors, which is pretty much the same as before. But the really, the really substantial change that took place in 2020 is that squamous cell carcinomas are now divided into two different types. So that's HPV associated and HPV independent. So that is really now how you're going to categorize your squamous cell carcinomas. Sorry, I'm just trying to move you guys around a little bit. So depending on when you graduated, you'll see a lot of these historic terms that were really tied to traditional morphology. So, when you would describe squamous cell carcinomas, they would be keratinizing or non-keratinizing, basaloid, verrucous, or warty. And really, in recognizing the growing importance of biology and etiology on treatment and prognostication, now squamous cell carcinomas of the vulva are really just separated into HPV associated and HPV independent, which means that all that sort of traditional morphologic terms that you used in the past no longer apply. And this is really a broad approach taken by the WHO across a lot of the lower genital sites. So this dichotomization of HPV associated and HPV independent, doesn't just apply to vulvar squamous cell carcinomas, it also applies to, vaginal tumors and cervical tumors. So, and it really sort of harmonizes the whole approach across this publication. Why does HPV matter? I think HPV has mattered for a very long time. We've, and this goes back to like 20 years ago when Dr. Kerman, started to notice that there are different, different clinical, different precursors, different behavior for depending on if vulvar squamous cell carcinoma was HPV independent or HPV associated. And there have been a lot of very sizable series that has shown that, HPV independent tumors do a lot worse than HPV associated tumors. So, they have a worse overall survival, worse rates of local recurrences, they have higher rates of lymph node mets, they're much more likely to be margin positive, and they're much less likely to be responsive to chemoradiation. So for all of these reasons, now we try our best to categorize squamous cell carcinomas again into HPV associated or into HPV independent. So the question for you guys now is, okay, great. So the WHO has come up with this recommendation. It has now been incorporated into our guidelines, and now it's your responsibility as a pathologist to tell the difference between HPV associated and HPV independent. So of course the question now is, well, how are you going to do that? So, there's a variety of ways that you can do it, right? So if you were to go with morphology, so you could, most of our HPV associated, they're much more basaloid, much more blue, and then your HPV independent is much more well-differentiated or keratinizing. But if you were just to go on morphology alone, you would probably misclassify the tumor in about 20 to 40% of cases. And say, what if you use sort of circumstantial evidence? So what if you were to use the in situ lesion? You might be wrong in about 5 to 20% of cases. So just relying on morphology alone, will get you far. It will get you, 80% of the way, but you're still going to be wrong in about 20%. And so for this reason, we actually have endorsed that P16 is done in all invasive squamous cell carcinomas in order to accurately classify them into HPV associated or HPV independent. So P16 is now really considered a core item or a mandatory item for squamous cell carcinoma of the vulva and vagina. And, the head and neck folks have done this for many, many years. So, it was sort of a shock to some people that now they have to do this. But, the head and neck folks have done it. We're pushing for the same sort of reflex biomarkers in endometrial cancer and, ovarian cancer. So it's, vulvar cancer is just taking a little bit longer to get there. But again, this is sort of the 2021 recommendation. So how do you interpret P16? So, for the most part, it's fairly straightforward. So you're looking for diffuse and strong cytoplasmic and nuclear staining. And you want it to be in at least 1/3 of the epithelial thickness. And that's because, squamous squamous cells still mature, so it doesn't have to be 100% of the cells, but you just want continuous staining in at least the lower 1/3. And of course, for all the newbies there, P16 tends to have sort of blushy staining, and I actually like to see sort of weak blushy staining in negative tumor areas and in the normal skin, because it tells me that the stain has worked. But again, a little bit of patchy positivity is not positivity. That's actually considered negative. Okay, so the other big update that you guys should know about is tumor grade. So tumor grade is actually no longer recommended for vaginal vulvar squamous cell carcinomas. And this is also true for cervical squamous cell carcinomas. And we'll talk a little bit about why. The ASCO has also removed grading for their head and neck squamous cell carcinomas. And eventually we might replace grading with pattern of invasion, like fibromyxoid stromal response, or like a pushing infiltrative border. Tumor budding may become sort of important histologic prognosticators, but right now we don't actually grade squamous cell carcinomas. So depending how you see it, if you're a traditionalist, you grade this for so many years, like how can you let go of something that has been in your textbooks like ever since you started residency? It can be a little bit hard to let go of. But I think David Chappelle, he said this like really nicely, maybe it's a little bit, sort of, cathartic to kind of like let it go, that you don't have to do this anymore. And this is really the point, right? So if you look on the left-hand side and you were to give this invasive squamous cell carcinoma a grade, you would say, well, it's keratinizing, it's got lytic cytoplasm, it's going to be a grade 1 squamous cell carcinoma. And if you look on the right-hand side, this is a poorly differentiated tumor because it's got, a very little cytoplasm, it's got high NC ratio, and you'd probably call it a grade 3 squamous cell carcinoma. But the reality is that grade does not tie to prognostication very well at all. So if you look on the left-hand side, that's an HPV independent tumor. The overall survival for 5 years is about 40 to 60%. And on the right-hand side, if that's grade 3 or poorly differentiated, it has a 5-year survival of 90%. So it's a bit counterintuitive for our clinicians, and it doesn't really make a lot of prognostic sense. So for that reason, we have really got rid of grade. There is some talk about, should we grade the HPV independence and not grade the HPV associated, but maybe that's something that will change down the line. But right now, the most important prognosticator is really HPV and not grade. Okay, so depth of invasion. Depth of invasion is like, it's like a little bit of a circus in 2021, but I think you'll see it's not too bad. But so depth of invasion is obviously something that you guys have to report in your pathology reports. And really the most important cutoff is 1 millimeters. So if a depth of invasion on a biopsy is more than 1 millimeters, then the patient is going to go for an inguinal-femoral lymphadenectomy. And that is really associated with a lot of patient morbidity, a lot of lymphedema. So essentially, this is a really important point of dichotomization. So how are you going to measure depth of invasion? So there are actually 2 different ways of measuring depth of invasion. So there's sort of this traditional method of measuring depth of invasion, which is from the superficial dermal papilla adjacent to the tumor to the deepest point of invasion. And what that means is you actually have to have a superficial dermal papilla adjacent to the tumor, which sometimes you have and sometimes you don't. And then the alternative method is a little bit more conservative and actually ends up downstaging some tumors. And that is from the basement membrane of the deepest dysplastic rete ridge to the deepest point of invasion, which is what they do in the cervix. And this ends up, again, downstaging about 20% of 1Bs to 1As, and they spare 20% of patients from an inguinal-femoral lymphadenectomy. So great that there's 2 methods, but like, what are you going to do now that there's 2? Like, which method are you supposed to use? So this is where it gets a little bit confusing. So The ICCR is recommending the conventional method. It is the method that we have been using for a very long time. We didn't think there was enough prospective studies to change the method, but FIGO actually recommended the alternative method in 2021. And CAP, which came later, actually said that you can use both. You just have to state which method you're using. So it's a little bit in flux, but just know that this is really only going to change your stage 1A tumors, which is a pretty small number of patients. So margins. Margins is another item that has changed, and it has a lot of caveats and nuances, but so essentially for margin distances, you are required to report a margin distance for invasive squamous cell carcinoma. And the magic number is 8 millimeters after formalin fixation. A lot of people more recently have started to question the 8 millimeter cutoff, like, is that really appropriate? It doesn't take into account HPV, and so people are starting to question this, and different studies have recommended more conservative margins. But for right now, the official guidelines do still endorse the 8 millimeter clearance. And then for high-grade in situ neoplasia, generally the recommendation is 0.5 centimeters or 5 millimeters. And then, if you are reporting, you don't have to report LSIL, and then you don't have to report distance for the in situ neoplasia. So how should I measure margin distances? There's actually a really nice paper that was published by Kim Kordigas and Jalin Bossi, and they always show this image because I think they have really nice schematics. But essentially what you're just trying to do is the shortest distance to the edge, and don't be too creative, right? Just go, you don't have to take into account the folds or the overhang. Like, you want to go into tissue, straight into tissue, and take the shortest margin distance. So ancillary testing, we talked a little bit about P16, right? So P16 is one thing, but the other IHC that you might do is P53. And I think there's a lot of sizable, well, maybe not sizable, there are actually a few studies now that have shown that P53 is an adverse prognosticator, particularly in the HPV-independent squamous cell carcinoma group. So a lot of people will do P53 for prognostication. And certainly here in Vancouver, we always do P16 and P53 upfront on all of our tumors. And the other reason to do P53 is actually to assess for in situ neoplasia if you're unsure if there is a background of DVIN, and also for margin assessment. So one of the hardest areas in gynecologic pathology is this whole concept of differentiated VAN, which is still continuing to evolve. And part of it is that the morphologic features are really, really hard. If you don't see a lot of cases to detect, and so P53 is actually really good. And in our institution, we've picked up about 1/3 of our cases actually had in situ neoplasia that was not reported in the original report, and about 1/5 of our cases actually had a P53 mutation at a margin that was not actually originally recognized in the original report. So for us, we do P53 for prognostication, and we do P53 for clarification of margin status. And when we looked at our cases, if it didn't matter if it was differentiated VAN with high-grade cytologic features at a margin versus, something that was a little bit more subtle with P53 mutation at a margin. It didn't matter what the morphology was. If there was a P53 aberration at a margin, it was associated with a 3 times increased risk of recurrence after 2 years. So for this, we're fairly liberal in doing P53 for margin status. So when you should be doing this? Well, this is a bit of a tricky question and probably requires like another hour to go through. But I would say, you just have to be very cognizant that the spectrum of DVIN is much wider than you were probably taught in residency. It doesn't have to be as thick or acanthotic as it normally is. There's lots of different variants of DVIN. So keratinizing DVIN, atrophic, acantholytic, hypertrophic, and just sort of, if you see anything sort of histologically abnormal at a margin, just have a low threshold for throwing on a P53. You'll probably ask me this later, like how many P53s am I supposed to do? Generally I do about 3 or 4 on a radical vulvectomy, and I'll pick up the margin. Thus any margin positive is a positive margin. So I do about 3 or 4. I don't think you have to go crazy and do 20 on all of the margins. Like pick your most suspicious blocks and do the P53. Basically the same thing I said earlier. So yeah, have a low suspicion, and generally I do 4 blocks or less. So lymph nodes, you're going to report for lymph nodes all the parameters anyways, but things to keep in mind that FIGO has actually changed. So if there is a lymph node met over 5 millimeters, so they do use a different cutoff. For most cancers, we use 0.2 and 2 millimeters, but for vulva, they use 5 millimeters in FIGO. If there is extracapsular spread, or if there's fixed or ulcerated nodes, this will change the stage to FIGO stage 3. You're probably going to report all of this anyways, but just know that there are some extra parameters that will jump the stage, at least the FIGO stage, to stage 3. So squamous precursor lesions is another very, very difficult topic. And if you guys have like another 5 hours, like we could go over this, but it's pretty tricky. I'll just touch upon some high level details, and then I do have some cases that I hope will help you just a little bit. So for the precursor lesions, this again is harmonizing the WHO, right? So we're sort of moving away from sort of traditional histologic terms, and now there's sort of HPV-associated VIN and HPV-independent VIN. And of course, you can sort of subcategorize those. So under HPV-associated, you have L-cell and H-cell, and then under your HPV-independent VIN, you have these terms double, VAD, and DVIN. So what is the precursor lesions for HPV-associated neoplasia? Well, this is probably something that you're very familiar with. We've moved with the Bethesda sort of framework many years ago, but you have L-cell that's associated with low risk HPV infection and a negligible risk of squamous cell carcinoma. So again, you're looking for cholestatic atypia, so nucleomegaly, irregular margins, so pretty classic. And then H-cell, you're looking for sort of more basaloid atypia with suprabasilar mitoses and dyskeratosis. And this is associated with high risk HPV with a 10% risk of squamous cell carcinoma over 10 years. So again, that old criteria or the old nomenclature of VAN 123 is sort of being phased out. And that was part of the last guidelines. Like if you're a traditionalist, you could put it in brackets, but in generally, L-cell or formerly VIN1, and then H-cell is formerly VIN23. But again, that VIN23, just put it into brackets. So the HPV independent precursors are a lot more confusing. So some terms that you may have heard about is differentiated VIN, and this was sort of the term that was coined 20 years ago. And this was sort of the I guess would be the corollary to usual or undifferentiated VIN. So in the old term was undifferentiated VIN, which is also known as HSIL, and then the other side was differentiated VIN, and so that's where the term comes from. But this is an HPV independent VIN, usually with a lot of basal cytologic atypia, elongated irregular Ritchie ridges with fusing, and probably the most important feature, at least that I think is helpful in practice, is evidence of abnormal maturation, usually in the form of very, very, very pink cells. So the cells are very plump and very pink, and usually not with a lot of inflammation. Then that's usually my first indicator that something is wrong and that this could be differentiated VIN. And then some other terms that have come forth in the most 5 or 6 years is VAD and double. And these are HPV independent lesions, but they tend to be P53 wild type, and they tend not to have basal atypia or nuclear atypia, but they do have evidence of abnormal maturation. So they're usually acanthotic lesions, lots of hyperkeratosis, parakeratosis, and they usually have a lot of dyskeratosis as well. But we'll talk about these in a little bit. And the other thing to keep in mind most recently is that we're really trying to push, sort of a molecular corollary. So for differentiated VEN, the vast majority are going to be p53 mutant, and then for VAD and DEVIL, they're going to be p53 wild type. You may have heard of another term called VAM, or vulvar aberrant maturation, that was coined by the ISSVD, and it's sort of an entity that encompasses both VAD and DEVIL, as a sort of a lesion with abnormal maturation, usually verruciform architecture, of uncertain malignant potential. But so there is a bit of terminology out there, and more recently, another term that has been proposed is verruciform acanthotic VAN, and that term was really coined to try to harmonize the VAN terminology. So lots of different things out there. Just be aware that they all exist. So that's it for the reporting, and then of course I have cases for you guys.
Awesome, Lynn. Really, really great. Such practical advice for us as we all work through these difficult things, like you said. Don't see anything in the chat just yet, but everyone, please go ahead and ask your questions or put your comments. Couple of things I actually wanted to ask you about that came up as you were going. One thing that I found that we struggle with, and you said this happens a lot in your cases, is when you have a p53 abnormal signal that goes to the margin, and that margin is morphologically not that abnormal. And you reiterated the literature and how you approach it. So I'm just curious, those you indicate as involved.
Yeah, I do, just because I mean, we have one paper here, and it would be nice if we had, more out there with reproducibility, but from our own experience, it didn't matter if it was like short of DVIN or not quite DVIN with a p53 mutation versus like full on DVIN with a p53 mutation. There was no difference in the recurrence rate. So they were pretty much identical. And then the other sort of interesting caveat too is that DVIN at a margin was more highly associated with the risk of local recurrence than your traditional, some of the traditional themes like tumor size, etc. So it was actually quite interesting. So that p53 at a margin is actually really important.
So Lynn, maybe a follow-up question to that. So if you have a large excision, how many p53 stains will you eventually perform? How many slides, or it's empirical? Just
yeah, that's a good question, because I mean that was the next question that we had when we published the first study. We're like, oh, now what do you do? Like, now that you know the importance of p53, like how many blocks am I supposed to stain? And so for the last few years, we've been putting in all our vulvas in total. Unless it's kind of like a breast lumpectomy, the way I see it. Like if it's clearly away, you're not going to put some of those margins in total, but for the most part, we put the vulvectomy in total. And then for the most part, like I can do about four stains or 4 blocks, and I just sort of pick what looks the most abnormal, and that can be anything. The tips to think about is it doesn't have to be really thick or really atypical. And then the other thing is, if you see atypia with a lot of inflammation, like don't just ignore it, because I think historically people see inflammation and they think, oh, it's just reactive, it's reactive inflammation, it's nothing. Like don't ignore the atypia. I should do the p53.
And we have the first question. How do you measure depth of invasion in verrucous carcinoma?
Oh, so hard. Yeah, I don't know if there's a good answer, because it's like pushing type of invasion. Probably the best thing to do is try to get an sort of a sense of what like the normal interface would be. But yeah, I'm not sure that I have a good answer. Best judgment, I guess.
Do you report the thickness, Lynn?
I do report the thickness if I'm in a jam. So, so a lot of the times you can get, exophytic squamous cell carcinomas or exophytic lesions that don't really seem to be invading deep into sort of that like original stroma, in which case sometimes you have to report the thickness. But I will do my very best to report the depth of invasion as well. So same thing with cervix, like sometimes you report thickness, but depth of invasion is if you can do it, like that's the better parameter to go by.
So we all see biopsies, and you mentioned kind of a change, at least in the pathology world, change in terminology. What's your sense of how the clinicians are adapting to that?
That's a good question. Yeah, so we're really lucky here. I think we have a really good tumor board, and we have good surge onc pathology rounds, and so we're always we're always communicating with our clinicians, and so they're very trusting, and they've actually they're very well versed. Like they know how important P53 and DVIN are. We also have a vulvar health clinic who are also very well versed. So, when we first were starting to diagnose double, which we never did for so many years, and then all of a sudden you're putting this term double on the reports. They were very open to learning about it and trying to figure out what to do. And we were, we actually wrote up a short case series on the double. So, yeah, I think it partly comes from the relationship that we've had before. But they've been really receptive about it.
Yeah. And so now that we're struggling with all this and using all these different terms, any treatment differences between HPV associated and HPV independent?
Yeah, no, that's a really good one, because at the end of the day, it all comes down to what's going to happen to the patient, right? So for HPV associated, there's a variety of treatments. So HSIL, there's a variety of treatments that go from just topical treatments, so imiquimod, laser, cryotherapy, or excision. But generally, they don't need to excise. There are alternative options. DVIN is a bit trickier, but the trend nowadays, and I think the most recent ESGO that was published, is that if you make a diagnosis of DVIN, it should get excised. So DVIN is considered a high risk lesion, and it will be surgically excised, and preferentially with 0.5 centimeter margins. The double, or the P53 wild type VAN, whatever you want to call it, the double, the VAD, the VAVIN, the VAM, that is a little bit trickier. I'll tell you what we do here, because I don't think we know very well what the natural history or biology is. So we'll say that, this lesion, or P53 wild type VAN, has been associated with a risk of, subsequent invasive squamous cell carcinoma. But we are, sort of unsure of the latency period and the proportion that transform. And then we sort of give them an option, like if it is easy or amenable to excision, then go for it, and if it's not, close observation is okay. And the reason why I say that is because we have diagnosed P53 wild type VAN going backwards, right? Like you see invasive squamous cell carcinoma, and then you notice a lesion that is beside it. But we actually have very few studies that have just looked at VAVIN, and then seeing how long or how many cases actually transform it. Is it over 10 years? Is it 20 years? Is it 2-3 years? There's actually very little data on that. And so for that reason, I leave a little bit of wiggle room.
There's another question in the chat. So it's regarding grading. Yes, I'm just going to read the comment. I think that I still see it as mandatory on the current CAP protocol. That's the comment. And then the question following says, is that supposed to change soon?
I think, yeah, CAP did retain it. I don't know if they will change it later, but I think that, yeah, well, I can't speak for CAP, so, but I think CAP did retain their grading, and ICCR took it out. But I think in the future we'll probably replace it with something else. But again, I can't speak for Kath.
We'll see what happens, right?
Yeah.
So yeah, with regards to biopsies and as you just illustrated for us, you know, the treatment differences at the time of making the biopsy diagnosis, you know, you iterated that doing P53 and P16 on biopsies is a practice that you follow no matter what the morphology. Is that true?
I usually do P16, P53 for all invasives. And then actually for the in situs, depending like for if it looks like an HSIL, like classic HSIL, I usually won't do anything. I don't do a P16, and that's not in the ICCR guidelines because we realized making that mandatory would be a lot of P16 because HSIL is to DVIN is like more than 10-to-1. So I only do it for ambiguous cases and for the HSIL that are a little bit funny looking. And then for the HPV independent, if I suspect, then yes, I will do both for an HPV independent lesion.
Great. I don't see any additional questions right now, so maybe Lynn will go to your first set.
Okay, sure. My first set will be really short, I think. It's just meant to reiterate. Sorry. Okay, sorry. It's always like juggling where to put you guys on Zoom and then the slides. Okay, so the first set's very straightforward. It's just meant to hammer home one of the key points. So this is case 1. So 55-year-old woman, you know, fairly classic vulvar mass. So here's what the lesion looks like. So a little bit of normal skin, a little bit of probably basaloid atypia, and then this neoplasm here. Here you can see a little bit more of it. Sort of destructive growth into the stroma. A little bit, a bit of a higher power for you. And then this is a little bit of sort of invasive areas, and then this sort of more warty area on the surface. And here you can see the sort of atypia, mitoses, hyperkeratosis, perikeratosis. Again, the sort of very blue look. So because you are very good and you know about the most recent guidelines, you did a P16. So this is diffuse and strong. Okay. So I will not do any polling just for the sake of time, but your diagnosis. So this is an invasive squamous cell carcinoma. And how are you going to classify it? Well, it's HPV associated. So again, you don't have to put in those morphologic descriptors, just HPV associated invasive squamous cell carcinoma. And again, just a reminder that this is sort of the theme that the most recent guidelines endorse. So the second lesion, so an slightly older woman, 70-year-old with a longstanding lichen sclerosis, again, another vulvar lesion. So this is what it looks like. Lots of keratin. Lots of, I think, fairly unequivocal invasion. P16, a little bit of blush-like staining, but looks negative. So your diagnosis, of course, is invasive squamous cell carcinoma, HPV independent. So really, it just is just reiterating what we were talking about earlier. And that, I think, is it for set number 1.
So Lynn, does P16 correlate perfectly with HPV status?
It doesn't, but my next set actually has that in there. So you are you are on the ball and ahead of the game.
Because I think you know, we're using this ancillary tool to you know, put these into a category, which, as you know, beautifully told us, makes a difference. And we're kind of relying on it, but it's not perfect. It's not perfect. So we look forward to hearing more about that. So I think we're going to move on to our first participant case, and that's from Dr. Amir Samani.
Hi, good afternoon. I think you have my screen now, right?
Yep.
Okay, let me go to full screen. Yeah, I'm going to present a few cases of vasculitis in GYN tract. The first case, 67-year-old with bilateral fallopian tubes and ovaries. Case was in 2017. So what I found.
Amir,
yes.
sorry to interrupt. Are you
Sure.
able to flip your dual screen? Right now we see your presenter view.
Okay, let me see if. How to do
I
that?
think if you go to display settings at the top.
Yes.
Yes, so just yes, display settings, yep. And yeah, and swap. Yep, I think that should do it. Perfect.
It's better?
Yep,
Okay.
perfect.
Okay, thank you. Sorry about that. So 67-year-old female bilateral fallopian tubes and ovaries. I found multiple foci of vasculitis. And in this focus, for example, you can see number of lymphocytes into the vascular wall. And there are some giant cells. This is high power. This is elastic stain showing that the elastin layer is disrupted. So the patient has giant cell arthritis in both ovaries and fallopian tubes. So multifocal in multiple sites. Next case, 58-year-old female, THBSO for atypical endometrial hyperplasia. Again, in fallopian tube, I had a focus of vasculitis. This time, didn't have giant cells. It has more features of polyarthritis nodosa vasculitis form. And you can see again, same pictures, fibrinoid necrosis. And elastic stain shows disruption, fibrinoid necrosis. Next case is cervical cone biopsy done for adenocarcinoma in situ in this patient. Again, you see a large blood vessel with fibrinoid necrosis and lymphocytes in the vascular wall. Perfect findings for vasculitis. Subsequent hysterectomy in same patient showed multifocal vasculitis in cervix. As you can see, but no giant cells. The next case, 67-year-old bilateral ovarian fallopian tube. And in the left ovary, we had fibrotrichoma with a small foci of polyarthritis nodosa type vasculitis. As you can see here, a small foci. Another focus. You can see lymphocytes in the wall with disruption. Right ovary, medium and large size blood vessels also had, you can see multiple foci of vasculitis, polyarthritis nodosa again. So it was bilateral. These are the pictures with recanalization of some of the blood vessels, fibrinoid necrosis. Fallopian tubes had no pathological findings, no vasculitis. Another case is the leap done for the L cell. So close to the area of previous biopsy, I found a deep-seated blood vessel with vasculitis, only one focus. So this probably was more iatrogenic to the previous biopsy. As you can see, here some of the hemosiderin-laden macrophages. Another case, hysterectomy done for atypical hyperplasia. And again, close to the site of previous endometrial curettings, I found one focus of polyarthritis nodosa type vasculitis in the myometrium. very close to the site of previous curettings, most likely iatrogenic to the previous procedure. And this is the elastic stain. So vasculitis have different type of classifications. One of them is based on the size of the blood vessel involved. And based on that, we have different.
I agree.
Sorry. Okay. We have different type of blood diseases in this classification. Also based on the cause of the vasculitis, we have infectious diseases. For example, Hep C. Some parasitic infection can induce vasculitis, systemic vasculitis, and even some recreational drugs having amphetamines or contraceptives can induce vasculitis. The way I report the vasculitis is, I mentioned in my report that I found vasculitis. I try to type the vasculitis if it's either giant cell arteritis type or polyarteritis nodosa type, the type of the size of the blood vessel involved, where the location is, and how extensive it is. Is it single or focal, multifocal? And I usually use this in my comment that vasculitis has been reported in female genital tract either as an isolated disease or part of systemic vasculitis. Clinical and serological correlation recommended. Further treatment may not be necessary if there is no systemic disease. And I refer to these two publications which had reviewed multiple cases of the vasculitis in GYN tract. And I briefly present these two here. One of them is this paper from France, and they reviewed 118 cases of vasculitis in GYN tract. 108 of these cases were isolated polyarteritis nodosa type. And among those 108 cases, 66% only involved cervix. But they didn't mention if this patient had previous cone or curettings or pap smear to see if it's iatrogenic or not. And 10 cases in their series were giant cell arteritis. And in those giant cell arteritis type, 50% limited to myometrium, which is interesting. And in their case series, 99% of their cases had no progression to systemic vasculitis. I should mention that based on the search that I did in 2 different hospitals that I collected these cases I presented to you so far, we've had no systemic vasculitis reported in these patients in our hospital, Meditech. The other paper that I usually mention in my report is this paper from UK, and they reviewed 46 cases of the vasculitis with follow-up. They said that among these 46 cases, they find out 3 patients with polyarteritis nodosa type, furtherly developed extragenital vasculitis, vasculitis with rheumatoid arthritis, and polymyalgia rheumatica. And one of their cases with giant cell arteritis had previously documented with temporal arthritis. So this was my short presentation. I'm happy to have any questions. Thank you so much for giving me this opportunity.
What amazing, amazing photos. Really like a textbook of vasculitis. Amazing.
You're welcome.
Yes, so there's a question which it's related to a question I had. I mean, you mentioned that none of these patients ended up, to the best of your knowledge, actually having a systemic vasculitis, which as you said, is the kind of traditional teaching, I guess. But there's a question from the audience about if you know if any cases had subsequent serologic workup and correlation.
Unfortunately, when I checked out on Saturday, actually, I checked out our Meditech, and I found that unfortunately, none of clinicians did anything for these patients. I think they just clinically find out that patient has no rashes or no complaint of headache or anything, and they basically didn't think that it's necessary to follow it up with the patients. But as I can say that because it's a research kind of work now, I couldn't use the Connecting Ontario to see if the patient had any follow-up anywhere else. We cannot use Connecting Ontario for research. So at least in the institutions, 2 institutions that I did this, collected these cases, no. The answer is no.
Yeah, I think amazing cases. Thank you, Amir, for presenting
You're welcome.
this really amazing. I'm glad that clinicians at least reading the reports and doing something, because most of the time they, I think, will miss this in our reports.
Hope so. Yeah, thank you.
Okay, thanks again, Amir. Lynn, back to you.
I'm going to.
Oh, sorry about that, Lynn. I muted myself. Any comment on vasculitis before you start your next set?
Oh no, that was a fantastic presentation. Yeah, we get asked that a lot in rounds, and I think that's like the perfect way to go about it. I think to mention whether it could be systemic or just an incidental sort of tumor associated vasculitis, and those are the papers that I also quote. So we're on the same page. Set 2, I will try to make quick. Okay, all right, so set 2, Dr. Hodgson has is on the ball. So this is a 60-year-old with a vulvar mass, and this set really tries to talk about P16 and P53 and sort of some of the pitfalls and some of the complements. So again, sort of invasive squamous cell carcinoma, looks very blue, very basaloid. You know, if you were to guess, you would probably guess an HPV-associated lesion. But you do your P16 and it's negative or it's patchy, and you're thinking, oh, like, is this a mimic? Like, this is very odd. This is not what I was thinking. One of the things that you can do is actually do a P53. So P53 actually has some very specific patterns in HPV-associated lesions, and this is one of them. This is sort of a variant of basal sparing, where you get no staining in the basal layer and a portion of the parabasal layer, and then you get this really, really strong P53 staining in the middle of the squamous nest, and this is a very HPV-associated pattern. So if you don't have HPV testing at your hospital, probably you're going to have P53, and so it's actually really, really helpful. And so, in this case, we did do the HPV-ish, and it is positive. So this is actually a false negative P16 IHC. So I gave you the diagnosis. I think this is an HPV-associated invasive squamous cell carcinoma. So we don't have a lot of time to go over the different patterns of P53 staining. But again, there is this basal sparing pattern that you see in HPV-associated lesions. The classic pattern, you have absolutely no staining in the basal layer and lots of staining in the parabasal layer, which is the entire opposite of a wild type tumor. You will usually have more staining in the basal layer, and then it tapers out as you get more central. So this sort of opposite should trigger you to thinking this is an HPV-associated lesion. And of course, there are variants to basal sparing. So sometimes it's not just the basal layer, it's a portion of the parabasal layer. And actually, sometimes it's almost all of the layers, and it almost looks null-like, and in which case you might just have to do the HPV-ish. But the other interesting finding is that, these cells that don't have P53 are because the HPV kicks out the P53 protein. And if you do the HPV-ish, it's those cells that don't express P53 that have a lot of HPV in them, which makes in biologic and intuitive sense. This, it's a busy slide, but it just goes to show, like, the vast majority of time you're going to have complementary P16 and P53 staining. And just to draw your attention to the very bottom, so this is a P16 negative tumor, but the P53 shows a basal sparing pattern, which is a P53 pattern, and this happens in about 1% of cases. And so this is still an HPV-associated SCC despite the P16, and there are a variety of biologic mechanisms why you would get a false negative P16. So second case, so this is a patient with a recent diagnosis of devil. So this is the lesion. So it looks like the sort of exophytic, warty looking lesion with sort of big, broad nests. Sort of a very spiky or verruciform lesion at the very top. And maybe you can convince yourself there's like maybe a little bit of sort of microinvasion coming down from some of these invasive nests. And some area adjacent to the tumor. So there's a bit of basal atypia, there's some mitotic activity, so it doesn't look completely normal. So this again draws back to like, when do you do P53 and your biomarkers? When you see something that's like just a little bit off, and you do the P16 and it's positive, right? It only has to be positive in at least 1/3 of the epithelial thickness. And this is contrary to devil, sorry, because devil is supposed to be HPV independent, but your P16 is positive. And you do your P53 and it actually shows this basal sparing pattern. So, you know, again, you're thinking, well, this is probably an HPV associated lesion. And you can see it nicely in this in situ area, where you get no staining in the basal layer and positive staining in the parabasal layers. So this is actually not a devil at all. And then more sort of basal sparing. Sometimes you really, really have to look for that basal layer. So what is your diagnosis? This is an HPV-associated squamous cell carcinoma. So you know, devil is very, very rare, and this just goes to emphasize that you know, morphology is not always going to help you. P16 is pretty helpful, and P53 is really helpful. So case 3, 75-year-old vulvar mass. And Anjelica, you can stop me if I'm going over time. So so this is a core needle biopsy. So we have an invasive squamous cell carcinoma, you know, probably some in situ neoplasia. You know, what are you going to do? You're going to do your P16 and it's positive. And if you're like me, you want to do the P53 because you know how important the P53 is. But, you know, if it's P16 positive, I would expect that this would be some sort of basal sparing pattern. And it is not. So this is actually a mutational pattern. This is diffuse overexpression. So this is confusing, right? Because if P16 is positive, well, P53 should show some variant of basal sparing and it doesn't. So what does this mean? So HPV-ish is negative, and this case was actually sequenced. I don't think I put it in there, but there actually is a missense P53 mutation. So diagnosis, HPV-independent invasive squamous cell carcinoma. So again, most of the time your P16 and your P53 are going to be complementary. In about 5% of cases, you get a double positive. So if you have a double positive P16 and a mutational pattern for P53, that P16 does not represent HPV. It actually is an HPV-independent SCC, and that happens in about 5% of cases. So, so that's just another pitfall. But that is it for set 2.
Lien, sorry, can I stop you here with the last case? To me, P16 was not quite obviously overexpressed when you showed it. Can you comment? Yeah.
Yeah, I think there's some inflammatory cells in there and probably some melanocytes. Maybe you get like a little bit of negativity in there. But I guess the other thing would be, you know, you got to know your own stains really well. And like for us, this would be a block-like positivity. But same thing with P53, like you got to know what your P53 looks like in your hospital, and then you can kind of titrate from what's abnormal and what's not.
Lynn, there's a question just again about using P16 and P53 in tandem and whether, you know, they should always be used in tandem.
For my invasive squamous cell carcinomas, I always put them together. So I always do them together. So I think some people do them in tandem for cost saving measures. And it would say, you know, as a pathologist, if you practice a lot and you see a lot of vulvar squamous lesions, you always have this radar that something is funny. And so you will know when to do one marker or both markers and what is just like a classic bona fide, like HPV associated, etc. But I do always do them together.
There's also a comment about a question rather about your opinion on the utility of Ki-67.
I never do it. Yeah. So we tried doing it for the in situ lesions, particularly to see if it was helpful for VIN. And it was just all over the place. The only time I find Ki-67 helpful is actually for LSIL, because LSIL has a Ki-67 that is the flip of normal. So normal is you always have Ki-67 sort of more in the basal layers, and then it gets weaker as you go to the surface. And then for LSIL, it actually is the opposite. So you have more Ki-67 on the top and versus at the bottom. But it's a really subtle pattern. But I find that's helpful for the diagnosis of like condyloma versus just a squamous papilloma. But otherwise, I never use Ki-67.
There's another question about the devil case regarding the sequence of events. So was IHC not done on the biopsy that was called devil?
It was, and it actually was misinterpreted. Yeah. So because I did go back and pull the biopsy, and the P16 was called negative, but I think the P16 was diffusely positive. Yeah.
Got it.
Yeah, it was a reflection, I think, of like enthusiasm. Like everyone is really hyper vigilant about the devil, and they think everything is devil now. But it's like, no, it's really, really rare. Like if you're gonna make that diagnosis, like be really sure of yourself. It's not common at all.
Right. Okay, that was great. We're going to move on to the next audience case, Dr. Michelle Weir.
Great, thanks, Anjelica. Can you hear me okay? Do you want me to turn my volume up?
Sounds good to me.
Thank you. So I'm going to share with you a 58-year-old woman who had a lesion in her endometrial cavity that was seen on hysteroscopy. They thought it was an endometrial polyp. We're wondering about a fibroid. And so we received an endometrial curetting and a polypectomy. It was done by one of our general GYN surgeons. We embedded it in 4 cassettes. It looked like a typical, kind of like almost like an ablation with lots of endomyometrial, really cooked and cauterized fragments. So on first look, you can kind of see some proliferative endometrium, doesn't look too exciting, and a little bit of smooth muscle as well. But then you start to see a more diffuse pattern where we're not seeing the endometrial glands anymore, kind of a stromal-rich area. And looking around through the cautery, you can almost see a little bit of a sunburst pattern with these very prominent collagenous bands and this small blue cell proliferation. Some of them look a little more spindly. And in some of the areas, they start to get more clustered. It's sort of almost a gland or sex cord type pattern. We also noticed that the sex cord pattern also seemed to come up into the endometrial mucosa itself and was encircling some of the gland areas. This is a very challenging case because there was a lot of cooking and cautery artifact. But we also noticed as we were looking at this that there seemed to be some very prominent interdigitation with the myometrium. So I had a differential here, knowing that these were little curettings and there was a lot of cautery. I did go ahead and do some immunomarkers. The things on the top of my list was this actually endometrial stromal? Certainly looking at those sex cordae or glands. I even wondered about certolofoid endometrioid adeno as a component. I also wondered about pecoma. It didn't really fit at all the morphology. So I went ahead and did a CD10, probably didn't even have to look at it on the scope. It was so positive in the sex cord-like areas, but also in a lot of those stromal areas too. And the small blue cell type pattern was nicely positive. Smooth muscle actin patchy, but some areas that were positive, and also some of the sex cord areas too. The WT1 Wilms tumor was really pretty. So we actually had nice positivity, especially in the sex cord element areas, and diffusely positive ER as well. Kind of knocked your socks off. Everywhere it was ER positive. PR was as well, and cyclin D1 was kind of patchy, very, very weak, nothing to write home about. I did a large panel, so my keratins were negative. I did more smooth muscle markers. Desmond and Desmond were negative. My HMB melanA for PCOMA were negative. And I did some other sex cord markers like inhibin and calretinin. Those were also negative. So I signed this out after showing it to a couple of my friends, Dr. Etler and Dr. Goebel, who held my hand on this, that we felt this was a low-grade endometrial stromal neoplasm with sex cord differentiation, and the differential was an endometrial stromal tumor or nodule versus low-grade ESS, and we really favored the latter. I showed you where the sex cord elements were looking like they were going up into the endometrium, and they were also interdigitating, almost infiltrative with the myometrium. So she went to hysterectomy in September. I'm not going to show you that. And at hysterectomy, it's a low-grade endometrial stromal sarcoma. There certainly was sex cord differentiation, but certainly not as prominent at what we were struggling with on the curetting. And very similar immunomarkers for that, except the SMA, interestingly, was very focally positive. It wasn't diffusely positive at all. So I thought this was a really good case to try and think about how do you report these on little curettings, not to go all the way to malignancy and just to sit there because you're not seeing a good edge to this lesion, but also a nice, I think, wake up for me is to be really careful in some of these cauterized endometrial curettings. Thank you so much.
Wow, awesome. Awesome case, Michelle. Lynn, comments?
Yeah, that's a really amazing case. I think the best thing, on curetting is to do, like you mentioned, do your immunomarkers and then mention your differential. I think I saw Dr. Goebel's name, or heard Dr. Goebel's name. She's like the pro at this, right? Because I think that the big differential here is between an ESS with sex cord differentiation versus a uterosc. If you have molecular disposal, really helpful, but sometimes just triggering that this is a neoplasm and triggering a hysterectomy, if clinically feasible, is probably the right thing to do.
Yeah, Michelle, so there's a question about molecular testing on this case. And my question to Michelle and Lynn is, do you pursue molecular testing on every case that would fall into this category or not?
Do you want me to go first, Lynn, or?
Sure.
We did not do that on this particular case. We would more likely pursue this in a higher grade ESS. So we're very, very selective in what we do it on. Thank you.
I'm very greedy, so I tend to do some sort of RNA like fusion assay. We don't have a broad enough one to pick up some of the fusions for the uterus, but it will for the ESS.
Great. Thanks again, Michelle. And Lynn, we'll go back to you. We can't hear you though, Lynn, if you are speaking right now.
Yes, thank you. So set 3 has a little bit of a mini theme as well. So this is a 72-year-old with a vulvar plaque and erythema. So you can see here, pretty large sort of excisional biopsy. We've got this sort of thick lesion on the left-hand side, a lot of inflammation, vascular ectasia, and then it sort of gets, tapers out as it go to the other side. And here you can see a lot of inflammation again. And then the other feature, probably the most helpful feature that worries me, is when you get these really, really big, plump, pink keratinocytes. And then, the way I think about it is it looks very spongiotic and very, very pink. And, you know, sometimes there is a lot of inflammation and sometimes there isn't, but this does worry me. And there's a lot of sort of disc keratosis as well. And the other thing to notice, sort of, it looks more worrisome on the right-hand side and then a little bit less worrisome on the left-hand side. But you'll see again, you know, even the lesion on the left-hand side, it's still abnormal, right? It's still got that hyperpinkness. It's got parakeratosis, hyperkeratosis. So even that I wouldn't say is completely normal. So here's another high power view, something that looks almost very, very spongiotic. In this case, there isn't actually a lot of intraepithelial inflammation or intraepidermal inflammation. And again, this just goes to show the other area that's less atypical, but still not completely normal. So here's the P53IHC. So it just goes to show that this is a mutational pattern. So this is diffuse or parabasal expression. So very, very, very strong staining in the basal layer. And in this case, it extends almost all the way up to full thickness. And this is a mutational pattern that is in the lesion that looked very atypical, as well as the area that does not look as atypical. So the, you know, this is a good example of like, if this were to go to a margin, you know, you would pick this block to stain because that lesion, even though is a little bit less atypical, is still not completely normal. So this would be a good block for P53. And we did sequence this, so this does have a confirmed P53 missense mutation. So diagnosis here. So diagnosis, differentiated VAN or HPV independent P53 abnormal VAN. And I'll show you the P16, but it was negative. So again, this just draws back to knowing that the spectrum of DVN is wide, right? You can get a trophic VIN, acantholytic, hypertrophic, etc. And I'll give you some examples. So this is another example of differentiated VAN. So this one actually has really broad pushing fronts. And, you know, I think if I were to look at this maybe 5 years ago, I might think this is like a verrucous carcinoma or something. It's got really broad pushing areas. This is the P53. So this is a P53 mutational pattern with a confirmed missense mutation. So again, you just have to have a really low threshold to do P53. So this is another example. So this one is not as thick perhaps, but you can tell that there are some abnormal features, right? So you've got fat britty ridges. They're not fusing, but they're still abnormal. There's disc keratosis. There's some mitotic activity, hyperkeratosis, parakeratosis. So, you know, it looks abnormal. You're not entirely sure what it is. And if you do the P53, so here, this is a null pattern. So you have no staining in the squamous cells and you have a good positive internal control. So this is another example of differentiated VIN that you could have mistaken for even just like lichen simplex chronicus or something. So another one where I think the nuclear atypia to me is never as bad as you think it is in differentiated VIN. Like it's always a little bit atypical, but the severe atypia that people talk about, I can never see. Like it's pretty rare to get very atypical DVIN. So again, P53 mutational pattern. This also has a confirmed mutation. Here's another example. So thin or a thin DVIN. So this is not thick at all. Here you can actually see the nuclear atypia a little bit better. But you can see again, it's not completely normal, right? You've got hyperkeratosis, parakeratosis. A bit of a higher power view for you with the nuclear atypia. And this has a P53 mutational pattern. So continuous strong staining in the basal layer. Another example, this one is clearly atypical, I think. And, you know, if you were to take a guess, you know, you might think this is an HPV associated lesion, given how blue it is. But this is actually basaloid DVIN. P16 is patchy. And then your P53 is a null pattern. So this is basaloid DVIN. So just, you know, gives a good sort of array of all the different types of DVIN that you can see and just sort of have a broad mind and a low threshold. So this is a 40-year-old vulva pruritus and erythema. So very, very pink lesion. Okay, so sort of hyperkeratotic, so parakeratosis, a little bit warty. and sort of very, very pink. So when we were talking about, things that trigger me or, cells that are too pink, this doesn't have the actual like prominent intercellular bridges that you often see in DVAN, but it is still very, very pink. And a little bit, you can tell it's abnormal. So if you're thinking that this is DVAN and you do the P53, again, I've shown you this pattern. There's no staining or very, very little staining in the basal layer and lots of staining in the parabasal layer. So this is actually a basal sparing pattern. So this is actually, a HPV associated lesion. You do the P16, strong staining in at least 1/3 of the epithelial thickness. So again, that sort of fits. So the diagnosis here is not DVAN, it's actually H-cell. And this was a lesion described by Chris Crum and Jacqueline Watkins that talk about H-cell with superimposed lichen simplex chronicus or rubbing-like changes. And this patient also has Candida. So she's been rubbing a lot, and that whole basaloid look now looks much more pink or eosinophilic. So classic morphology for L-cell and H-cell, we talked about a little bit. And so this is sort of the slide to keep in mind. There's a mimic for everything, right? So DVAN is very, very pink, but there is a variant of H-cell that can look very, very pink. Your P16, your P53 will help you. Same thing for H-cell, that's a basaloid looking lesion, but there is a basaloid variant of DVIN. But again, your P16 and your P53 will be helpful. So just to give you a few more examples. So again, this is another lesion. It's not perhaps as acanthotic, but it does look a little bit atypical. Here's your P16. So, probably not what you were expecting, but this is P16 positive. I will admit is a little bit on the weak side. And I think there are some melanocytes in there. And your P53, so basal sparing pattern. So probably not what you were expecting, but this is the case of H-cell. And then you can, this is the HPV RNA-ish, and you can see that there is HPV in that basal layer. And that is it for set 3.
Well, your last set showed us that our ancillary studies betray us, and now this set shows us that our morphology sometimes betrays us. Lynn, question for how you, I don't see anything in the chat, question for how you report your P16, what terminology you use. So do you use the terms positive and negative, or do you use a more descriptive pattern type of thing, or how do you go about that?
Yeah, that's a good question. So, so I do use positive and negative, and then if it's negative, I'll put in brackets like patchy. And then for positive, I'll put in brackets like diffuse / strong. It's a really good question. It's the same thing for P53 that can be confusing, like positive, there isn't really a positive negative, it's a abnormal or normal. Same thing for MMR. So I usually will use positive negative with qualifiers in brackets, or normal abnormal with qualifiers in brackets. But yeah.
Okay. There's a hand up, Dr. Georgievic.
Hi, sorry, I'm having like some technical difficulties here, but I think, okay, here I am. Hi. Hi, nice to see everybody. And thank you, Lynn, for such a great session. I have one question. I'm looking at your diagram of the last kind of diagram where you showed kind of an algorithm where we go from P16 positive versus P16 negative. And my question is on the last branch where we have the P16 negative, but the P53 with basal sparing.
Yes.
And so my understanding from the previous papers was that P53 with basal sparing was a wild type pattern.
Yes.
So, okay, there it is. Okay. So could you just, I know you've explained this a little bit, but I missed it. So the rationale then in interpreting these, so we're understanding that P53 is normal, right? But then P16 is lost, and is it still thought to be lost due to an HPV related mechanism?
Yeah, this one's a rare and a tricky one. So the key here is that there are some cases of where it is an HPV associated lesion, but your P16 is negative. And so why is, there are a variety of reasons, like loss of heterozygosity is one,
Yeah.
like hypermethylation is another one. And how do you get out of that situation when you think it's HPV associated? So one, you could do an ISH if you have ISH, like RNA testing or HPV testing.
Yeah.
The other is just to do the P53, and the basal sparing is specific to HPV associated. So we did P53 on like tons of lesions. You only did an HPV associated. So that's the trick there, though it will only happen in about 1% of cases.
Yeah, I know we've just had a case not too long ago. We had a case like this.
Yeah,
It's given us.
Yeah, like depending where you practice, like what I say to my residents, like they're super rare, but like welcome to Vancouver, right? Like
I know.
Rare, but you see, like don't dismiss anything. And then you're absolutely right. So when we came up with the original paper, there are two different wild type patterns. So one is like your typical scattered heterogeneous, and one is your basal sparing, which is wild type. Like, and the reason why it's wild type is, we don't want you to confuse it with a mutant pattern, right? Like if you don't see the missing staining in the basal layer, like don't confuse it as a mutant pattern. So they are grouped under wild type. And then for the basal sparing, it's like specific for HPV. So, it's a lot to like wrap your head around.
Yeah, I guess in the absence of HPV in situ hybridization, then this basically gets signed out with a big comment, and hopefully doesn't happen too often. Great.
Exactly.
Thank you so much. Great talk.
Okay, we will move on right after Dr. Samani asks his question.
May I ask question now?
Yes, go ahead.
Oh yeah, I have a kind of biological point of view question. The P53 in basal pattern, the basal cells are progenitor for the maturing cells. So at the beginning, I agree that we have mutation happens in basal cells, but after few months, it should actually replace all the full thickness. But even in some of the invasive component, you only have basal P53 mutation, not in the nests. Why is that?
Yeah, that's a really good question. We don't know entirely, but it is exactly like you're saying. Like these squamous lesions are different than normal tumors. They still mature, like they still have, they're a little bit different like than your high-grade serous carcinoma and the P53 patterns that you see there. Like they still mature. And you're right, like just the basal cells are the progenitor cells that have the HPV infection. And what's probably interesting is that as those progenitor cells mature upwards, some of them, and we don't really know why, like this is all up in the air. Some of them will actually kick out their P53 mutation. So Chris Crum has a nice study where he microdissected the superficial layer that doesn't have P53 overexpression from the basal layer that had a lot of P53. And the mutation was only found in the basal layer and it was lost in the parabasal. So we don't really know why, like it's a phenomenon of the natural life course of a squamous cell that matures, or is it something else? Like we don't know, but you did hit the nail on the head. Yeah.
Thank you so much.
And Lien, would you do HPV testing on some of those cases that are questionable?
Yeah, absolutely. Yeah, like we have the RNAscope HPV-ish, and I like it a lot better than the DNA. DNA, it's a little bit dirtier. And I would say from experience, the manual assay is actually a lot cleaner than the automated assay for the RNA scope, but the manual assay takes like 3 days, so we can't do it in all of our cases.
Okay. Let's move on to the next audience case, Dr. Madeleine Fitzpatrick.
All right, can you guys hear me okay?
Yep.
All right. Get started. Okay, so keeping along a similar theme, I thought I would bring two recent cases that we had within the department that I thought highlighted some of the challenges in vulvar biopsy interpretation, and having Dr. Hoang here, I thought would present a unique opportunity to get her input on some of these cases as well. So in terms of case number one, we have a 52-year-old female presenting with a several-month history of perineal irritation. Notably, she doesn't have any prior history of any vulvar dermatoses or dysplasia. She was started on some topical estrogen and clobetasol without much relief. And ultimately, she was referred to the gynecologic service, where an examination did reveal a flat ulcerated lesion involving the right labia majora, and a punch biopsy was taken. And so here's a whole slide image view of our lesion. And then on the low power view to the left, we can see that there is evidence of parakeratosis. And although the epidermis is not overly thickened, there are these nice elongated and anastomosing reedy ridges with prominent intracellular bridges. And then as you go on higher power towards the right, I think this is when you really start to appreciate the basal cell atypia, and there's some increased mitotic activity, notably right here. And so with these morphologic findings alone, I think our suspicion was fairly high for a differentiated VIN. We did go on to do our IHC, and if you're anything like me, I initially got a little bit excited when I first took a look at our P53. But I think this case serves as a good reminder to avoid interpreting P53 on a low power, because actually once you go on higher power, the P53 in this case is actually somewhat difficult to interpret, with areas of probable overexpression here to the left, amongst other areas that appear more wild type. And then for completeness, we did do our P16, which was not overexpressed. So ultimately, this case was shown within the department, and the consensus was that since there was unequivocal histologic features of DVIN, even in the presence of this sort of equivocal P53 staining pattern, a diagnosis of DVIN was made. And on to our second case, we have a 59-year-old female. She's been followed by gynecology for a long-standing history of hypertrophic vulvar lichen sclerosis, as well as recurrent DVIN, which was most recently recurred approximately 1 year prior. She's also been treated with some topical progesterone and clobetasol. And then on her most recent visit, however, she was noted to have some new white lesions on the left labia majora, and a punch biopsy was taken. So here's our whole slide image view of our second vulvar biopsy. And even on this magnification, again, you can see some nice hyperkeratosis, but you see this time that the epidermis is more acanthotic, and it has more of these broad and stubby reedy ridges. And even on this magnification, I think you can appreciate the prominent band of inflammation involving the superficial dermis. And so then when you go on higher power on this lesion, for me, like the basal atypia in this case just wasn't as striking as it was in our last case. And having all this superimposed inflammation, it can sometimes make it difficult to distinguish reactive cytologic atypia from true dysplasia. But regardless, I think there were some atypical features and maybe a scattered mitoses that was seen. Nevertheless, we did go on and we did our P53, which as we go on high power, it does show a strong linear expression along the basal layer with extension into the parabasal layers as well, which we now know is consistent with an aberrant overexpression pattern. And similar to our first case, P16 was not overexpressed. So for this case, we ended up pulling the biopsy from the previous biopsy. And again, we showed it within the department. And ultimately, although the features were not entirely diagnostic of DVIN, given the aberrant P53 and its similar appearance to the previous biopsy, a diagnosis of DVIN was rendered. So in terms of a few take-home points, as much as we want them to, the lesions don't always seem to read the textbooks. And so with that, I think our level of certainty, especially when it comes to diagnosing vulvar lesions, is really going to vary case by case. So for example, if your lesion has unequivocal morphologic findings of DVIN, I think you can be pretty confident in making that diagnosis. And likewise, if your lesion has features that made you suspicious enough to order the P53 in the first place, and then your P53 comes back as one of those abnormal staining patterns, I think then too, you can kind of hang your hat on that and make that diagnosis as well. But I think when you fail to kind of critically evaluate the morphology and then you start ordering P53 a little bit more liberally, sometimes that's when things get a little bit more difficult to sort out, and then your level of certainty might start to drop off. But basically, I just wanted to bring these two cases to highlight that these cases can be quite challenging in practice, and even for some of our, seasoned gynecologic pathologists. And so, whenever in doubt, I would recommend, pulling previous biopsies or showing the cases to a colleague, as these steps can be quite helpful when working through some of these very difficult cases.
Daily diagnostic challenges in vulva always. Lynn, comment.
Yeah, those are phenomenal cases. That was an amazing presentation. So the first case, I think you did exactly what I would have done. I don't diagnose DVIN unless I see a P53 mutation, and I know that is not in the textbooks, but I just think P53 ties so well with biology and prognostication that I don't make a diagnosis with DVIN. And so in that case, if you have some atypical features, you're worried, you just, being descriptive and then correlating with the history or with the clinical appearance is really important, right? If there's a big mass lesion, they can excise, and they just took a small biopsy, that it probably is something sinister. And the other tricky part that everyone has encountered is P53 in inflammatory lesions, very, very difficult. You set your threshold higher. So anything that is, proliferative, anything that's got more inflammation is going to have more P53. It is going to be stronger than normal. And, if you're not sure, I wouldn't call it. And, for us, if we get equivocal cases, we'll send it for sequencing. And the most difficult pattern that people always struggle with is the basal overexpression pattern. Is it basal overexpression, or is it just really strong wild type? Less than 5% of DVINs have basal overexpression. It's really, really rare. And almost every inflammatory lesion has strong wild type. So in those particular cases, if you're not sure, either I would refrain or I would send it for sequencing. So yeah, if you see the basal overexpression is not entirely reliable, it's much harder to distinguish. But in your second case, if there's an obvious mutational pattern and you're convinced, then you're out of the woods. And then I don't know if you noticed, but the picture you have is great because there was a hair follicle in it. That serves as a really good control for wild type, and you can see the juxtaposition of the different patterns, and so it's really convincing.
Lynn, one thing that you've said that you do is send these vulvar lesions for sequencing. And I speaking for myself, but I think I'm speaking for the other pathologists from Toronto here, that we don't have access to that and or do not do that. So any comment on that?
Yeah, I know. I'm a greedy little bugger. We piggyback on our POLEs because we do POLE testing for endometrial cancer, and it's on a cartridge with 20 cases. So often if we don't get 20, we're going to fill it up anyway. And so I actually end up ordering the sequencing because I can piggyback off the endometrial cancers. But I totally realize the vast majority of people will not have this. So again, it draws back to, if you see a P53 aberration, be convinced, I would say, a good null pattern, good cytoplasmic pattern, or diffuse pattern, call it. And if you're not sure, especially with the basal overexpression, it's okay to be conservative. It's okay to convey uncertainty. Yeah.
Would you suggest to rebiopsy those lesions for those of us who don't have access to sequencing?
Yeah, so clinical history is very important. Oftentimes the clinicians see a giant 3-centimeter mass they're just not telling you about. So first, have a really good relationship with your gynecologist, your gyne-oncs. And the other is to really convey like rebiopsy or really close clinical follow-up.
And what is your threshold in general? I think this inflammatory lesion that was shown to you second probably has some abnormal features. It was too thick.
Yeah.
And so on and so forth. But some of them are relatively akin normal. So what is your threshold for ordering P53?
Yeah, I have a really low threshold. So yeah, in that case, I think with the sort of hyper pink cells, I would definitely do it. But in general, yeah, I have a very low threshold of doing it.
Lynn, a quick question from the audience. What NGS panel does your institution use?
We are a bit of an outlier. We use the Connexia Find It panel. It was developed in BC, so I think probably we are the only ones in Canada to use it. But it's a 33 gene panel, poly MSI, and then a bunch of targetable molecular aberrations or targeted therapies on it. So yeah, but we are a bit unique.
Diana, comment?
Yeah, I wanted to circle back to the issue of invasion in vulva. I'm not sure, Lynn, if you were there for the recent ISGIP online meeting, but there was a presentation there where that showed, they talked about the measurement of invasion. And I remember looking at some of these images where I could have sworn I wouldn't have called invasion at all. So that kind of scared me. And I know often, we show cases like this at our intradepartmental conferences all the time, where there is a lesion clinically, but we cannot call invasion. So I just wanted to know what your approach to this was. Do you level these things like crazy? Do you reorient them? Sometimes I think it's almost impossible to call invasion, and yet we have this big lesion sitting there that we know is there clinically.
Yeah, I was not there and I haven't seen the talk yet. It was on my to-do list for this weekend, but I ended up painting my basement. So but it will be listened to. Yeah, the depth of invasion is so hard. It's like one of those, exophytic growth versus endophytic growth, and like how do you measure that? I don't know if I have a good answer. Like I try my best to find the dysplastic ready ridge and measure downwards. But yeah, I don't know if I have a really good answer to that. Like especially like the pushing type invasion or the invasion into a stromal, like into the sort of an exophytic polypoid lesion that doesn't seem to be going into the baseline stroma. Like they're really hard, but yeah, I best judgment. Yeah, I don't know.
There's no Vancouver magic on this one, I guess.
No. There's probably some like proteoglycans or extracellular matrix proteins and basement membrane, but no, we are.
Fair enough. Thank you.
Great. Thanks again, Madeline. Lynn, on to you.
Oh, okay. So, let's go to set 4. There it is. Okay, so this is my last set. All right, set 4. Okay, so this is a bit of a hodgepodge. So this is a 86-year-old with a verrucous lesion and what the clinician calls areas of skin hypertrophy. So you can see this is a scanned image. So maybe a little bit of more normal on one side, and then you have this very, very hyperkeratotic lesion, a little bit sort of warty verruciform. And I'll give you some high power images here. Sorry, it's really pink, but doesn't really have a lot of basoatypia, but it is definitely very acanthotic, lots of hyperkeratosis, a little bit of parakeratosis. And here again, you can see sort of this very almost warty kind of look to the surface. Again, just some more images for you to chew on, but not a lot of basoatypia, not a lot of mitotic activity, but again, really pink. It's this like hyper pink look to it, prominent intracellular bridges, but not a lot of intraepithelial inflammation to explain that sort of spongiotic look. So it's almost kind of like a mimic of spongiosis. And that's sort of my triggers for something is very odd here. So P53 was done, it is wild type, so sort of like patchy staining in the basal layer. Diagnosis here, very tricky. So this is actually a differentiated exophytic vulvar intraepithelial lesion, or P53 wild type VIN. So these are, you know, again, these are HPV independent lesions, P53 wild type lesions with a risk of subsequent invasive squamous cell carcinoma, but again, of sort of uncertain sort of time interval, and proportion of transformation is a little bit uncertain as well. So for these lesions, I don't know if I showed you, I find them exceptionally hard. And, you know, again, for these cases, I do my P16 and I do my P53, and I just want to make sure I'm not missing some sort of HSIL with superimposed lichen simplex chronicus. And these lesions are, you know, usually sort of, they usually have a well-defined sort of border to it. But I would say they're exceptionally hard to diagnose. And this was diagnosed because it did have an HRAS and a PIK3CA mutation in it. And again, you know, I'm lucky because I can, anything suspicious, I can just throw into the panel. And it helps me titrate sort of what the spectrum of devil is. But honestly, they can be exceptionally difficult to diagnose. And then to keep in mind, we talked a lot about vulvar squamous lesions and the whole, you know, VIN, but just remember that they are very rare, and probably when you're out in practice, you're going to see a lot of different lesions. So this is one lesion with sort of these, you know, paler areas, again, very sort of verrucous hyperkeratosis, and the keratinocytes are sort of falling apart here, or they're, you know, acantholytic. So this is an acantholytic hyperkeratosis, usually sort of a self-limited idiopathic lesion of the vulva. Rare sort of hereditary causes, but generally you would see it in a younger demographic. So keep that in mind. Here's another lesion, you know, sort of thick and elongated reti ridges. This one is very subtle, but some of these sort of fat discohesive cells here. So this is CK7 positive, MOC31 positive. So this is a case of extramammary Paget disease. So again, not everything is VIN, right? So here's another one that I actually thought was going to be a VAD, because it had this sort of like thick layer of hyperkeratosis and parakeratosis. And, you know, what's sort of, you know, subtle here perhaps are these sort of balloon-like keratinocytes. And so this is actually a contact toxic reaction with ballooning keratinocytes. And the clinician had actually called and said, like, this patient had some mental illness issues and was actually putting bleach on the vulva. And so this was very helpful to correlate with the clinician. Otherwise, I probably would have thought it was some sort of VAD or variant of it. Here's another lesion. Again, sort of these looks like invasive squamous nests, but if you kind of take a low power look, it all has a very smooth border to it, and it's very inflamed. There's some eosinophils in there, you know, there's some plasma cells in there, but very inflamed. This is a syphilis stain. This patient actually has syphilis. So just, you know, VINs are scary, but they are very rare, and just don't forget everything else on your differential.
Holy moly, that syphilis case. That was impressive, that stain. Lynn, question, when you find yourself in this category of, you know, HPV negative, P53 wild type, do you try to use the terms VAD or devil or whatnot, or do you just call this HPV independent P53 wild type VIN?
Yeah, that's what we're doing now. P53 wild type HPV independent bin. That's what we do. And then you can explain in your description the different terminologies, this uncertainty in clinical behavior, and that's the terminology that I prefer. Though you are absolutely right, there is a lot of other preferred terminologies out there.
And yeah, I mean, Anna, do you have anything to add, or?
Yeah, I think it's more terminology question, because some people actually call them in the DB an umbrella, and they just sign them out as DB, and they say, well, it's P53 normal, it's considered as a DB, and then the treatment should be as a DB. So we're a little bit on that.
Yeah.
Go with those lesions.
Yeah. Okay, great. I think we will move to the next audience case then. It's Dr. Catherine Connolly.
Thanks. Okay, great. So thank you for the opportunity to present. I'm going to present a very interesting recent case that we had. So the case history is of an 89-year-old woman. She had a short history of postmenopausal bleeding, and her imaging showed an abnormally thickened endometrium for her postmenopausal status, measuring 20 millimeters with cystic and echogenic foci, and an endometrial curettage was performed. So this is just a low power image showing the sample that we received. And I think that my attention was immediately drawn to the larger tissue fragments on this slide. So some of these fragments were composed of small, very tightly packed glands. And then other fragments had larger, irregular dilated glands. And actually in this image up in the top left-hand corner, you can see some of the patient's background endometrium, which was quite exuberant given her age and her postmenopausal status. So then going on to high power within these glandular fragments, and we can see that they're composed of back-to-back glands lined by columnar cells with mild to moderate nuclear atypia and variably prominent nucleoli with eosinophilic and mucinous cytoplasm. And within the gland lumens, there was mucin and also acute inflammatory cells. And then within the stroma of the tissue, there is an acute inflammatory infiltrate as well. So at this stage, I did consider whether this could be cervical microglandular hyperplasia. So just comparing our case on the left with just an image of microglandular hyperplasia on the right, and we can see that they do share some morphological similarities. They both have quite crowded glands and some dilated glands containing acute inflammatory cells and inflammatory cells in the stroma. However, in the microglandular hyperplasia, there really is quite minimal cytological atypia. And I think in areas as well, we can appreciate that there is a reserved cell layer as well. And then just taking into context the clinical scenario as well. So cervical microglandular hyperplasia, as we know, is typically an incidental finding in women of reproductive age. And in our case, this is a patient in her 80s who was symptomatic with postmenopausal bleeding. So we went on to do immunohistochemistry, and P10 was quite useful in this case. We had loss of P10 in those atypical fragments. And it can be hard to interpret the P10 because there's retained staining in the stromal cells, but it's useful to compare it to the background endometrium here on the left, which had retained P10. This is just a higher power image of the P10 immunostain. And I think you can see within the columnar cells, there is loss of cytoplasmic P10 expression. So at this stage, I felt that this was a endometrioid carcinoma, low grade, with a microglandular hyperplasia-like pattern. But then looking around the slide a bit more, we noticed that there were these distinct fragments of endometrium, which had a very atypical lining. And in other areas, these were present as just detached strips of epithelium. And as you can see, these have quite a degree of nuclear atypia, a high nuclear to cytoplasmic ratio, hyperchromasia, and multiple nucleoli. And these are really lit up with P53 immunostain. with an overexpressed pattern in comparison to the background low-grade endometrioid carcinoma and the background endometrium, which had a wild-type expression of P53. And the P53 helped to highlight multiple fragments of this high-grade neoplasm throughout the specimen. We did WT1 as well, and this did show some positivity within these high-grade fragments. So in summary, we came to a diagnosis of two distinct neoplastic processes within this endometrial curettings. So firstly, we had a high-grade serous carcinoma, and we did make a comment in our report that whilst we favoured that these serous strips were of endometrial origin, given the WT1 positivity, we could not exclude an upper gynecological tract origin. And then our second process was a low-grade endometrioid adenocarcinoma with a microglandular hyperplasia-like pattern. So for me, this case had a couple of really good learning points. So I suppose firstly that there can be some neoplastic processes which can have benign mimics. And it's important to really analyse the morphology, but also take into account the clinical setting. And then secondly, that even in a very small specimen, there can be two distinct disease processes or neoplasms, and just to always be aware of that.
Awesome. Thanks, Catherine.
Thanks.
Lynn, any comment on finding multiple things in your specimens?
Yeah, they do happen. Like, you never think they will, but it always happens to you, right? No, I think that was a really good case. The microglandular like adenocarcinoma was a really good case. When I was a resident, I remember with signing out with Dr. Phil Clement, he would always be on the hunt for like a mitosis, right? So if he saw like a couple of mitoses, he's always going to lean towards microglandular hyperplasia like adenocarcinoma. And the other helpful feature, if you can find it, is like the reserve cells in the microglandular hyperplasia. If you can hunt, cervical epithelium has a reserve cell layer, a basal layer, and a luminal layer. And if you see it, it's actually really, really helpful. I've actually tried to stain it with immunos to see if it could help distinguish between the two entities, and it was not helpful. But yeah, no, really neat. So high alert all the time.
Catherine, there's a question about follow-up for this patient. Hysterectomy done yet or not?
It's actually a really recent case, only within the last couple of weeks. So I don't believe that the patient has actually had any follow-up as yet. So I'm not sure what the plan for her is, or what her other medical history is.
Was anything unusual in the biomarker status?
No, so this had ER estrogen receptor was positive, and some minimal progesterone expression, and normal mismatch repair.
Yep, so follow-up question, Catherine, the P10, you let us know about the P10 in the microglandular stuff. People want to know about the serous stuff. Was the P10 intact there?
Yes, I believe it was, yeah.
Yep. All right, Anna.
Well, I think it's a great mimicker for sure. Do we still have, Anjelica, time for one more, or what do you think?
I think so.
Okay.
Why not? So we have our last audience presenter, Dr. Olga Moshkin.
Hello, do you hear me?
Yes.
Yep.
Hi, everybody. So I will show you the case of 47 years female presented to emerge with severe worsening, significant vaginal bleeding associated with pelvic cramping. And actually she suffered from this uterine bleeding already for 1 year, increasing. However, it was assumed like perimenopausal changes in the women organism. So actually, from her history, I found that she had DVT previously, before presenting to emerge with this bleeding, and it was kind of unprovoked right-grown superficial thrombosis, and she was put on blood thinners. So after 1 month of putting on blood thinners, she developed severe bleeding. So she was assessed in emergency department, and very big uterus, 19 centimeter, was found. Gynecological consultation was done in a few days. However, the person by this time stopped bleeding, and she refused to do any investigations such as endometrial biopsy or IUD to help her, and she asked about definitive treatment. So in 1 month, she was treated. Subtotal hysterectomy was performed. And here you can see the specimen. It was very large, bulky uterus, uterine body received by valve, not exactly anterior and posterior half, and separately cervix. The cervix actually was not complete, so ectocervix was missing. Then I talked to gynecologist. He said it was actually technical, extremely difficult operation. So from her history, I forgot to tell that 10 years ago, she had a cesarean section, and she was told after cesarean section that she has pretty large leiomyoma, just like information. So here on the cut section, you can see area of necrosis and yellowish nodular structure within the myometrium. So probably you know the diagnosis already based on this yellow color. Here the one half. At one half, you can see very well developed mass, demarcated, necrotic, some kind of hyalinotic or calcified, and the rest myometrium infiltrated by yellow nodules. Another half, you can see, so probably it was left and right half, something like this. So you can see squashed endometrial cavity, distorted. So even, I think even gynecologists would try to do DNC, but it would be technically extremely difficult. You can imagine how you should go inside. Here's how cervix looks by valve. You can see endocervical canal, like on the side, and here the cervical tissue infiltrated by yellowish tissue nodules, which actually goes to resection margin. And one of adnexal structure was okay, but another one, which was right, was enlarged, and on the cut surface we saw again a yellowish nodule. So gross examination showed us the big uterus overall, like together with cervix, 20 centimeter length. Microscopically, you can see squashed endometrial surface with an active type endometrium, and here you already see the beginning or portion of tumor composed of small cells. Here's the section of myometrium, another one at lower magnification, infiltrate of small cells, monotonous. Here you can see the same tumor infiltrating like tongues of myometrial thickness, and here the vessel with the tumor emboli. Here's the larger image of tumor, very rare mitosis. Here's a section of fallopian tube, diffusely actually infiltrated by tumor, a residual epithelial structure present, and here is fallopian tube and extension to ovary, and here's the ovarian tissue. Sorry.
Olga, you can continue.
Infiltrated by tumor, and again vascular space with tumor emboli. Oh, come on, come on. So after checking all these microscopical slides, we submitted a lot of sections. We made the diagnosis hysterectomy, bilateral salpingo-oophorectomy. Morphologically, it was endometrial stromal sarcoma, favor low grade. Even the behavior was extremely bad. I was thinking I can find something making this stromal sarcoma like high grade, but no, it was absolutely monotonous. No many mitotic activity, no too many necrosis. Remember, I showed you the big nodule, well demarcated and calcified. So most likely it was previously described leiomyoma, infarcted, calcified. In this case, it was involvement of right ovarian fallopian tube, extensive LVI everywhere, margins positive, pericervical and serosal, and as I said, infarcted and calcified mass, which most likely was the previously diagnosed grossly leiomyoma. And we sent this case for external consultant opinion. The diagnosis was confirmed, pathologic state P, T2A and X, FIGO stage 2A, and molecular analysis was done and showed just F1 to 12 fusion gene. And thank you very much for your attention. I decided to show you this case because actually it was unique gross examination to, and we were talking this case like, oh, what it will be. Will it be leiomyoma, weird one with huge area of necrosis, or will it be endometrial stromal sarcoma? And all PAs were very happy, involved, and it was great case for gross appearance. And I would like to tell you that previously, for 13 years of working at Peterborough, I didn't have even one case of endometrial stromal sarcoma. I got this case, and actually my colleague has very similar case, but different gross appearance. Again, endometrial stromal sarcoma was sent from Mount Sinai, and the molecular was done as the same gene fusion was found, and that's it. And thank you very much for your attention.
Thanks so much, Olga. Really amazing gross pictures and really great correlation between your gross pictures and those microscopic images, especially that tube one. That was very cool. So we're just over time. So with that, I'm going to thank Dr. Hoang so much from all of us for joining us this afternoon and imparting her wisdom and just spending this time with us. I know everyone is very grateful, Lynn. So thank you again for everything.
You're welcome. You guys are amazing, amazing cases.
I also want to echo Anjelica and thank Lien for joining. Also, all the presenters, absolutely wonderful cases. I think all of us seen different pitfalls, and we have now even more questions, I think, than answers. And importance of overall clinical pathological immunohistochemical correlation and probably conveying uncertainty, I think is the most important lesson for me, at least in this session. So thanks everybody who presented the cases, and please keep your cases coming. We'll meet next time in 6 months. And I hope you will have something the same exciting as we had this time. And again, we're waiting for your evaluations. Thanks everybody. Thank you, Lynn, and bye-bye. Bye.